Let's turn our attention now to the relapse setting, and we have a plethora of new drugs approved, and we need to help people understand when to use these and when not to use these. NCCN has 8 different potential therapies to use at relapse. So let's work on the hypothesis our patient has had bortezomib, lenalidomide, dexamethasone, a transplant, and lenalidomide maintenance, and is now relapsing for the first time. Rafael, how would you treat that patient?
Well, I think I would go back to my previous point. I would want to see which type of relapse we're experiencing and also the risk category of the patient. But all comers, right now, I would say, if I had to say everything else being the same, my number one approach has been carfilzomib, lenalidomide, and dexamethasone for first relapse. The reason for that is I think...
Even if they've been on lenalidomide maintenance?
Yeah, for sure. And the intent of the...
You wouldn't switch to pomalidomide?
Yeah, the intent of your first wave of treatment, if you may, when you get to transplant, is to get the patient into that CR and hopefully into a cure. I know there's data showing very long duration of response in some patients. I think that intent remains for the first relapse based on the data of a CR of 30% in the Aspire data. Now, again, this is for the third time temporary. We'll see what monoclonals play in the next wave of clinical trials.
Does the speed of relapse matter? I mean, we know about genetic risk. What about the tempo of relapse? Aggressive versus non-aggressive, does that matter to you, Ola?
Well, I think this is another big question. So we all know that there are very many types of relapses. You have the slow indolent relapses, you have these aggressive relapses. I think we probably all agree that for the aggressive ones, we need to have powerful therapy. But for the indolent ones, I think you could basically ask the same question as we started off talking about when to start therapy at all, in the smoldering, or do you need to have symptom?
Do you wait and watch then, or do you, as soon as you see the protein going up, do you start treating?
Well, so what I was trying to say is that for that indolent relapse, I think one approach is to wait and to go in with more indolent therapy. You could have oral therapy, you could increase
when you
Revlimid.
say, what sort of indolent, okay, so
you could go up to 25 milligrams of lenalidomide if you were on maintenance and add dex. In my experience, it doesn't usually work, and it doesn't work for a long time.
I have had no luck with that either.
So I think adding, for example, carfilzomib, I think is a very powerful approach. And there are now new other drugs that are available. Ixazomib, daratumumab will be another option, and elotuzumab, etc.
So how would, you're a practicing community physician. Let's just assume, let's turn to this side of the table for a minute. This is a fairly rapid relapse, proteins are going up fast, patients getting some symptoms. Bill, what do you use in this?
Well, if I have someone, as you've described, who's been on lenalidomide and is failing rapidly and explosively, I would probably go to a triplet of carfilzomib, pomalidomide, dexamethasone. That's been shown to have a very high response rate. In fact, Jatin conducted the first trial with this combination, and it was highly effective.
James, what if it was a more slow, indolent relapse? What would you do?
So I think there's a unique opportunity in that setting to incorporate elotuzumab into that setting as well. And I think one of the nice things that we see.
What is elotuzumab for, in case somebody listening doesn't know about that?
Great question. So this is another, which is one of the new monoclonal antibodies that targets SLAMF7, which is expressed on plasma cells as well as NK cells. And so one of the exciting things about that is potentially that with this kind of immune stimulating component of the NK cells, you can get potentially long-term disease control. So for the perfect, I think, candidate would be those patients that are biochemically or slowly progressing to add in Len-Dex-Elo, because then you can really, when you start thinking about, you want to maximally leverage each one of the therapies that we have. And if you want to maximally leverage elotuzumab, that is the ideal setting. You're going to really leverage the benefit of elo, not that aggressive relapse.
Even if they're young, and even a young patient with an indolent relapse, you would think elotuzumab would be your choice as opposed to carfilzomib, for example?
I think carfilzomib is still a good option, but for the biochemical slow progressors without that really doubling of the M protein in the next month, for that patient, because when else are you going to use elotuzumab? Again, trying to harness when am I going to use each one of the therapies. And so
one of the challenges I've run into in my own practice is that the insurance companies have been quite strict about having to use elotuzumab with lenalidomide. Yep. And these are patients who have been on lenalidomide recently and are progressing. And to me, I found that a bit challenging then to work that drug in the younger patient at least.
I agree. If they're rapidly progressing, yes. But if they're slowly biochemical progressing just on single agent Len, I think for some of those patients, you're right. For a Len refractory patient, you don't want to use Len-Dex-Elo. But for potentially those patients who are progressing on low dose 5 or 10 very slowly, that might be a unique opportunity to kind of
What about
incorporate that.
pomalidomide with ELO? Is there any data on that?
So I don't think there's any data now in terms of POM plus ELO. I mean, I think biologically it would make sense, but I think it's important to have that data. And I agree with you for what Bill was saying, for a more aggressive relapse, I think carfilzomib-based therapy is going to be important, either carfilzomib Lendex or carfilzomib Pomdex.